Hello and welcome to this session with the title, Utilizing the Belin ABCD Progression Display at its Best. My name is Trisha de Jager, and on behalf of OCULUS, I would like to thank each of you for attending this session. I think our guest speaker today does not need any introduction. Professor Belin has worked for many years with his research and his work to enhance refractive practice with the Belin Ambrosio Display and also now in the Pentacam, the Belin ABCD Staging and Progression Display. Professor Belin, welcome and thank you for preparing for today. I know it's very early on your side. We appreciate you presenting. Before I hand over the floor to you, a few technical things. If any of you struggle with sound settings, at the bottom of your display, you will see these three little buttons. You can click on that, and that will enable you to adjust your sound settings if necessary. Another point, if you have any issues or any questions rather during the session, you will find the Q&A section on the right hand bottom side of your display. Please write it in there, and at the end of the session we will address some of your questions. With that, Professor Belin, I'm making you the presenter and you can start sharing your presentation. The floor is yours.
Presentation back on. Share. Okay, so you can see my presentation, correct?
Yes, we can.
Good. So what I'm going to be discussing today, as you heard, is utilizing the ABCD Keratoconus Progression Display. But as I normally always do, we're going to start with some background information. For those of you who may not be familiar with really the basics of how we built this progression display. And my slides are not advancing. Here we go. So this really, the whole thought process started back actually before 2015 when a group of us, and really the four multinational cornea societies, Asia Cornea, Pan Cornea, U Cornea, and the Cornea Society got together for the global consensus on keratoconus and ectatic disease. I think everyone now is familiar with this publication. And what did they conclude first about diagnosis, not about progression, but about diagnosis? What they said was the following findings are mandatory to diagnose keratoconus. And the first one was an abnormal posterior elevation, abnormal corneal thickness distribution, and realize there's no mention here of the anterior corneal surface. So this was really a major change from the historical diagnosis of keratoconus. And they also said that the best current and widely available diagnostic test was really tomography, be it either Scheimpflug or OCT, and that posterior corneal elevation abnormalities must be present to diagnose early or subclinical disease. Now, most of you are familiar with the Belin Ambrosio enhanced ectasia display. And the bad display utilizes something we call an enhanced reference surface to accentuate the ectatic pathology. And the enhanced reference surface works by taking the standard 8mm optical zone that we normally use to compute the reference surface, but it removes, we'll call it a 3mm zone centered on the thinnest point. And that's shown, I don't know if my pointer works or not on the slide, but you'll see here, we call this the exclusion zone. So in the Belin Ambrosio display, we remove, actually it's a more complicated than that. It's really a variable number based on a complex formula between 3 and 4, but we're just going to say 3mm. We remove a 3mm zone from that 8mm optical zone. And what that does, it normalizes that reference surface by taking out, for patients who have keratoconus, the bulk of the ectatic region. And then it further accentuates the pathology. Well, that works very well. And we realized that after doing that it works well because that 3 millimeter zone represents the bulk of the ectatic region. So as opposed to removing the exclusion zone as we do in the bad display, if we want to really look at the cone, we should examine the exclusion zone as it represents the bulk of the ectatic region of the cornea. And again, it represented a difference from the past. The past, everyone always did apical reading, and here we're taking that exclusion zone, that 3 millimeter zone, centered not at the apex, but at the thinnest point of the cornea. And we came out with a new classification or grading system called the ABCD, and that was because Ambrosio, which still many people unfortunately use, is a 70-year-old system that's based on a keratometer and an optical pachymeter. And it only really evaluates the anterior surface. So the ABCD did a number of advancements. One, the A stands for the anterior surface, or the anterior radius of curvature, again, taken from that 3 millimeter zone, centered on the thinnest point. B was for back or posterior radius of curvature. C was minimal pachymetry, and again, Ambrosio, or most grading systems are apical, and we know the apex of the cornea in ectatic disease is not the thinnest point, so this is the C is the thinnest point on the cornea, and D is not an objective measurement and not a machine measurement, but distance visual acuity. In addition, if you think about Ambrosio, everyone in the world has at least stage 1 disease. So we extended this to include a stage 0. Now, stage 0 doesn't mean normal. You can have ectatic change that's very, very mild, but we want to expand the range. So we have actually 5 stages going from 0 to 4. And each anatomical layer, anterior, posterior, and corneal thickness, are individually graded. Now, currently, the ABCD staging is part of the topometric keratoconus staging display. And we actually give you 3 different bits of information. The actual staging is shown down here on the bottom. Now, actually, this is the least informative bit of information. Here we show it in a graphical analysis, and there you can actually see where it actually falls. So you can see here, while we have D0, you'll notice it's almost out to level 1. But the best information, or the individual information, is here, shown here. And these are the actual values. Now, this is something probably my host, OCULUS, won't be crazy about. And I put it here and I crossed it out so it wasn't so hostile, but I'm not crazy that it's part of the topometric keratoconus staging display. And why is that? Well, let's look at this example here. Here we have an anterior axial curvature map that looks fairly normal. And if we look at the topometric display, removing the ABD classification, you see the anterior sagittal curvature front, anterior sagittal curvature back, and they all look very normal. And if you look, excuse me, at the indices in the bottom left, except for a yellow for IHD, you'll notice everything looks completely normal. And TKC, also, everything looks very, very normal. But let's add in now the, well, sorry, jump. Let's look at that same patient on the bad display. You can see this is anything but a normal eye. If you look at the final D shown on the bottom right, it's almost 4 standard deviations from the norm. If you look at the pachymetric tracing, it is abnormal. If you look at the posterior cornea, it's abnormal. And if you look at every single parameter, it's either yellow or red, except anterior parameters. The anterior surface is normal. If you look at K values, they're normal. K max is normal. Front elevation is normal. But every pachymetric or every posterior surface parameter is abnormal. This is a highly abnormal eye, but a normal anterior surface. If we look at the ABCD grading, you again will see we have abnormalities on the posterior surface and corneal thickness. So this is a topometric keratoconus staging. I think sometimes it gives people mixed messages. If you look at the indices here, they all look fairly normal. And that's really because these indices were there pretty much to mimic what you would see on a placido system, which is only the anterior surface. And you'll see here, however, this is anything but a normal cornea. So that was a little background. But I often get a question is, why do we need a separate progression display? Can't we just follow the final D from the bad? Or can't we just follow the parameters from the ABCD staging system? Well, the Belin Ambrosio Enhanced Ectasia Display was designed specifically for refractive screening. It was designed to separate normal from abnormal. The final D shows variance from normal, but by itself is not necessarily specific for keratoconus. And what do we mean by that? Well, if you look at the bad display on the lower left, it's highly abnormal, but this is a post-refractive eye. If we look at the upper right, it looks very much like a keratoconic cornea, and it looks like an anterior ectasia, but again, this is hyperoptic LASIK. These are all eyes that are not normal, and rightfully so. They'll have an abnormal bad display, but they're not, quote, keratoconus. And if you look at the lower right, this is something you typically will see on patients with corneal edema or endothelial dysfunction, as opposed to a pachymetric tracing that dips down. This one is very flat because we have corneal edema and we see abnormalities on the posterior surface. Again, an abnormal bad display as it should be, but not keratoconus. So if we really compare the bad display to the progression display, which we'll get to later, the bad, as I said, was specifically designed to separate normal from abnormal. Very useful, but not specific in itself for ectatic disease. It's really designed for risk analysis for refractive surgery. Now, it can be used as one inclusion criteria for keratoconus studies, and we actually have been using it, but we add some additional information like abnormalities on the posterior cornea, as again mentioned in that consensus document. The final D shows deviation from normal, but not necessarily progression of disease. Now, the ABCD progression display was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals. So we're only interested if the cornea steepens or if the pachymetry thins. And it allows for documenting progression in spite of a stable anterior surface because, again, it grades each anatomical layer individually. Then we get a question, well, it's not the bad, can't we just follow the parameters of the ABCD staging system? And specifically here, I'm referring to the part on the bottom, the actual staging. Well, the ABC was really designed more for population-based studies, not to follow an individual patient. And what do we mean by that? Well, let's look at this example on the lower right, which is body mass index. If you look at normal, it's anything from 18.5 to 24.9. That means someone can, in this grading system, can start off at 18.5 and go all the way up to 24.8 and not have a change in their grading, though they've had a huge change in their BMI. Another individual can start at 24.9 and just go slightly more to 25, and they'll jump a whole grade. So grading systems like this are really designed more for large population-based studies, not great for following individual patients. So going back to that consensus document, how did the consensus document define ectasia progression? First, they said, again, realize this is back in 2015, they stated that there was no consistent or clear definition of ectasia progression. They said that it's defined by a consistent change in at least two of the following parameters. And this is the important part. where the magnitude of the change is above the normal noise of the testing system. And that is either steepening of the anterior corneal surface, steepening of the posterior corneal surface, or thinning, or an increase in the rate of corneal thickness change from the periphery to the thinnest point, or pachymetric progression. So again, I just want to highlight that. They stated, again, at least two of the following parameters. But again, I think the most important thing was a recognition that it had to be above the normal noise variability of the measurement system. Now, if we look at all the prior progression parameters in the literature, and if you look at this entire list here, spherical power, spherical component, Kmax, Kmax, Kmean, back optical zone radius of best fitting, which made no sense, increase in K-power, cylinder, et cetera, all of these, except for pachymetry here, are anterior parameters. So really in the past, people defined progression really based on the anterior corneal surface. And the most commonly used parameter, and still unfortunately for at least insurance companies, is Kmax. Reliance, unfortunately, of Kmax, and a lot of people are forced to use it based by insurance coverage, is resulted in a delay of treatment, because now we have to wait for that anterior surface to show further pathologic change. In other words, really, the patient has to have more sequelae. And it's delayed intervention, and also has eliminated our ability to pick up disease at its earliest stage. Now, this would be kind of like coming into your doctor with high blood pressure, and the doctor goes, yeah, you have very high blood pressure, but we can't treat you till it gets even worse. This is not what we normally do in medicine. The goal of medicine is to prevent sequelae, not to wait for sequelae to develop and actually wait till it even gets even worse. So we needed to identify ectatic disease earlier than, I don't want to say previously possible, but at least previously by utilizing Kmax. And we need a better way to classify disease severity. And we needed to know when and if disease progression occurs, but more importantly, we needed to know when it occurs at the earliest possible stage. So the Belin ABCD Progression Display, specifically designed to follow and document disease progression. As I said already, it's based on one-sided confidence intervals. It allows for documented progression in spite of a stable anterior surface or stable Kmax. And I think this is one of the major advantages of the display. Again, it allows us to identify all stages of disease, not just late disease, and evaluates each anatomical layer individually. And I already described this, but the ABCD classification, again, the A is that anterior radius of curvature, B is the posterior radius or back, and again, not an apical reading, but taken from that 3 millimeter zone centered on the thinnest point. C is minimal corneal thickness, and D, from the progression display, we show it, but really we don't analyze D because that's not a machine-generated parameter. As I said, we needed to determine the background noise for each of these parameters. Now, at least the A and the B parameter are new parameters, so we didn't have noise measurements for these. Again, this all sounds very confusing. I think most of you know that this is all done automatically by the Pentacam. There's nothing you need to do. And we also decided early on that it was, when we were trying to develop the noise measurements, inherent noise measurements, that it was important to look at two different populations, a normal population and we say abnormal, but a keratoconic population. And why was that? Well, for your very early disease, subclinical disease, or very young patients, the measurements here probably more closely mimic, at least the noise of those measurements, more closely mimic a normal population. Now, we all know, whether it's on the Pentacam, whether it's on almost any measurement, refraction, keratometer, whatever it is, the more severe a disease is, like keratoconus, the more variability or noise measurements are inherent. We all know that. So for the very early patients, again, the subclinical, we typically utilize the database based on the normal population. But for your older patients with clinically evident keratoconus, the noise levels from the keratoconic patient database are more appropriate. Additionally, the younger patient with very early disease, we know younger patients tend to progress more rapidly and the risk of waiting is higher. So we use the normal database because, again, it allows us to pick up disease progression earlier. Now, again, you don't need to know any of these numbers because they're all, again, the machine does it automatically, but we looked at standard deviation and then we developed what's called a one-sided or one-tail confidence interval. Again, one tail because we're only interested if the cornea steepens or it thins. And if you look, the noise measurements for the keratoconic population is in red, for the normal is in green. Again, you don't have to know these numbers, but just what you'll notice is what we would have anticipated, that the noise measurements for the keratoconic population are larger. In other words, they're noisier than the noise measurements for the normal population. And we show these both in 80% and 95 confidence intervals. Again, so that you as the surgeon can determine your risk benefit with the patient. And this is, I can no longer say the current because we just released, which I'll be really discussing towards the end, the third iteration, but this is the second iteration of the progression display. It allows you to show up to 8 exams. This has actually been increased to 10 with the third iteration, but allows you to show 8 exams over time. It shows it against the both 80 and 95% confidence intervals, in red for the keratoconic population, in green for the normal. The 95% confidence interval is a solid line. The 80% confidence interval is shown as a dotted line. You can determine your initial baseline shown by this little green dot. And if you do a treatment, and here treatment really we refer to as cross-linking, you can show that down here when you've done a treatment, and that treatment is shown as this dotted line. What you will notice is if you indicate a treatment being done, there are no confidence intervals after treatment because, again, these noise measurements were developed in non-operated normal and keratoconic corneas. The top half of the display I just explained is the graphical analysis. Again, A, B, C. And again, you'll notice distance visual acuity doesn't have confidence intervals because, again, it's not an objective measurement. The bottom, we show you in tabular format a number of different parameters if people wish to follow it. We show you the date and hour of the exam, the ABCD classification, the final D reading, progression index, ART max, Kmax, Q values, and a number of anterior parameters. So again, a lot of information on one single display. As I said, I'm just showing it so it's a little bit easier to see, so I enlarge it. It defaults, baseline defaults to the first, but you can select any exam that you may want for baseline. And then again here, you can put down when you've done a treatment. It defaults to showing both the red and the green flags or confidence intervals, but you can choose either population that you want to display. And actually, I do think it's probably an advantage for you to show only the one that you're going to clinically use. So again, if you have a very young patient, I would suggest just showing the green. If you have an older, showing the red. Reason for that is, again, you'll see later, it's just easier to read the display. And here you can see that this is the same patient, but here I've chosen to show the normal population gates, the green, and here I'm showing only the red. So again, this makes it a little bit easier to see. Also, some medical legal reasons, particularly if you're dealing with a young child. You don't want someone going, well, doctor, why did you treat this patient when they haven't reached this level? Because you wouldn't be utilizing the red, you would be utilizing the green. So again, it's easier to read, but again, it will default to show both. And I already said that if you show that you've done a treatment, those confidence intervals are removed because they The red and the green are based on preoperative non-surgical based normals and preoperative non-surgical based keratoconic patients. So let's look at a couple of examples to show you the clinical utilization. This is a 15-year-old with advanced keratoconus. If you look down here, you'll see the final Ds are 11 all the way to 15. If you look at Kmax, 56, 60, you'll notice that it continues to get worse and worse. So this is a 15-year-old with advanced progressive disease. And if you look at, again, Kmax, clearly it's well past that 1 diopter change. And if you look graphically, you'll notice that the anterior surface, constant progression, posterior surface progression, corneal thickness progression, every parameter is well past the 95% confidence interval on either the green or the red. But this doesn't show really the clinical advantage of using the display, because here Kmax shows progressive change. Well, let's look at this example. This is a 15-year-old, very early disease, and actually I picked one of the earliest possible. If you look at the ABCD classification here, they're all zeros, but if you look at the final D, you have 292, 334. So again, this is true disease. But let's look at Kmax. I have it circled here, but I have it blown up over here. Notice 46.1, then 45.5, then 40. Absolutely no statistical change in Kmax. Doesn't meet anyone's 1 diopter or 1.5 diopter criteria. But let's look at the ABCD progression display. The anterior surface is absolutely stable, and you'll notice that from Kmax. But look what's going on in the back of the eye. Posterior surface, by the second exam, is past the 80%. By the third exam, is well past the 95%. This is progressive disease. This is when you really want to treat. Waiting till you get a change in Kmax by 1 diopter or 1.5, depending on what criteria you're utilizing, means the patient's going to suffer a decreased vision. You don't want that. This is definitive progressive disease, but a stable anterior surface. This is when you want to intervene. Here's another example, a 16-year-old, again, fairly early disease. Look at the final Ds. Kmax here is changing just under that 1 diopter requirement, 48.9 to 49.8. So this patient would have to come back again and hopefully get even worse. But let's look at the progression display. The anterior surface, again, this is a 16-year-old, so normally you would only be using the green gates. By the second exam, well past the 95% on the anterior surface, well past the 95% on the posterior, and past on the corneal thickness. Every single parameter here is beyond 95% confidence interval, in spite of the fact that most insurance companies would not reimburse because it's not a 1 diopter change. Again, we have now enough in the literature, more and more coming out, that's going to show the validity of the ABC progression display, that you should be able to submit this to your insurance company. Here's an 18-year-old with stable Kmax. Again, you'll see here the anterior surface is stable. Here we're just at the 95% confidence interval, but let's look at the other eye. Again, the anterior surface is stable, but let's look at this posterior surface, dramatic progressive disease. Again, with stable Kmax. Now, it's not just early disease that we see this. This is a patient with advanced keratoconus. If you look at the final Ds, they're above 7. And if we look at the circled here in red, we have a stable Kmax, again, fairly advanced disease. And if we look at the anterior parameter, again, it's stable. But notice that, again, the posterior B and corneal thickness C, we see here, beginning of progression. By the fourth exam, we're out past that 80% confidence interval, and corneal thickness, we're out past that 95% confidence interval. So again, progressive disease in a patient with advanced keratoconus with a stable Kmax. So how do we diagnose progression of disease? We recognize that there is a dissociation between clinical progression and changes in Kmax. We now have a tomographic-based classification system that recognizes all the anatomical layers, a tomographic-based progression display that documents when we have statistically significant change. And also, it can be used on your older historical files if you want to go back and review past information. So that leaves us big introduction to the newest thing, and that is, well, how do we define progression after cross-linking? As I mentioned, currently the confidence intervals, I'll say currently, version 2, the confidence intervals of the ABCD are removed after you've indicated a cross-linking treatment. So we had to then generate, just like we did for the normal and keratoconic, we had to develop what the noise levels are for post-cross-linking. So we did a study to, again, measure the noise of post-cross-linking eyes and to evaluate whether these measurements can serve as progression determinants for progressive evaluation after cross-linking. Now, we decided something right in the beginning, that because this is a surgical procedure, there probably, or there could be some inherent variation between centers. So we actually utilized 2 centers. We took patients from the Elser Institute in Switzerland and the Hamburg Keratoconus Center in Germany with a minimum of 12 months post-cross-linking. Again, most people feel that most of the post-cross-linking eyes have stabilized by that 12-month period. As I said, we used 2 sites because it's a surgical procedure with some inherent user or site variability. We did 3 separate Pennacam measurements, and we looked at both pooled variance and one-sided confidence intervals. And we actually compared geography and also time since treatment. So what did we come up with? Well, let's first look at the patients. We looked at a total of 60 patients. 38 were from Zurich, 22 were from Hamburg. The average age between the two were very similar, roughly a little bit under 30. But the time since cross-linking between the 2 different geographic sites was significantly different. Again, we had a minimum of 12 months. The Zurich population averaged 16.6 with a range of 12 to 28, and the Hamburg averaged 42.6 with a range of 16 months all the way out to almost 10 years. And then we looked at the noise measurements, and the noise measurements, again, in red are from that keratoconic population, green is from the normal, and the blue you see now are the post-cross-linking. And what you'll see on all the measurements, whether it's A, B, or C, is that the post-cross-linking measurements actually fall in between the normal population and the keratoconic population. We then did a geographic comparison, and what we found is that the populations have similar ABC values, and they also, we show it now graphically below, they have similar noise measurements. So there wasn't a difference between the 2 geographic populations. Now these graphs may be a little bit difficult to interpret because they're not normalized. The N value here is 38 and here is 22, but these are actually identical. There was no statistical difference in the noise measurements between Hamburg and Zurich. Now the Hamburg population allowed us to look at another interesting thing because the Hamburg population varied from 16 months all the way out to almost 10 years. So we looked at a subpopulation of 1 to 3 years and 3 to 10 years. Each of these ended up with an N of 11. And if you look here at the graphs here, there was no statistical difference in noise measurements between patients 3 years and less and 3 years and more. So once you get past that 12 months, it appears that the noise measurements seem to be stable. And that's important to know. So this is the new and was just released 3rd iteration of the ABCD Progression Display. And when you look at it right now, it looks almost identical. And that's because we're only showing here a patient that has not been treated. Again, one of the changes it does allow now, instead of 8, up to 10 exams over time. So again, just like the second version, the post gates will not appear if your exams are less than 1 year. So you'll notice here again, this patient was treated, and you notice there's no gates that show below this crossed line, the cross-linking line, because if you look, none of the exams here are at least 1 year out. So even though this is the third iteration, the one that has the post-cross-linking, if your exams do not exceed 1 year after cross-linking, those confidence intervals will not show. So now here is the post-cross-linking gates that appear because we have data that's at least 1 year or longer. And you'll notice again, this is the preoperative data above this cross-linking, above this hatched line. This again is the normal confidence interval, the keratoconic confidence interval. And here you will see now that we have in blue the cross-linking confidence intervals. And again, they will only appear on the exams. You notice this line actually only begins on the exam that's at least 1 year or longer after treatment. Now, there's an awful lot of information on this display, particularly now since we even allow more exams to be displayed. So the exam can get very busy looking. Now, there's a lot of information, but sometimes when you're looking at it, you wish it was a little bit easier to see, and that's fairly easy to accomplish. First, you can clean it up a little bit by selecting the appropriate preoperative gates. And here again, this is a 16-year-old who was cross-linked, but here we selected only the green gates because a 16-year-old, which we want to compare to, again, that normal population. So if we go back, see if I can back up one. We look at this, which looks very busy. It looks a little bit less busy here because we've now only shown the green preoperative gates. We can make it even easier to interpret because really, when you think about it now, we're no longer interested in the preoperative data. The patient's been treated. So you can use the select exam feature here, and you can select the exams you want to display. And in this case, what I'm going to do is, except for the immediate exam before cross-linking, I'm going to remove all those preoperative exams. So again, we're now looking post-cross-linking. We want to determine whether we have a good result or maybe the patient might need a retreatment, and we're only interested really in the exams after treatment. But I'm going to leave the one right before treatment. So here, if you notice, I've removed all the preoperative data except for the one right before treatment, and notice how much easier it is now to look at this display. So again, the immediate one right before treatment, and now these are our post-treatment exams, and these are our confidence intervals. And you can see here, patient looks like they have a very good result. And again, this is another example where, again, we've made it much easier to see. We're only showing the one exam before treatment and then the exams afterward. And again, a good response to cross-linking. Now, here's an example of a patient who may potentially need a retreatment. You'll notice again, this is the treatment line, and you'll notice the second exam here. We're actually on the anterior surface, so progressive disease. On the posterior surface, out to about the 80%, we're seeing some progression, and nothing statistically significant on corneal thickness, but the trend is that way. Now, if this was my patient, I probably would still follow him at least for another exam, but clearly this is a post-cross-linking treatment that needs, post-cross-linking patient that needs closer follow-up. So again, this makes the little, here I'm just actually showing only the post-cross-linking exams, and you can see how much easier it is to read the display. So this is that same patient as this, but much easier because here I'm only showing the exams after the patient was cross-linked. Much, much easier to interpret. So again, you can see here the anterior surface, we're showing some progression, showing some milder progression on the posterior surface. but the corneal thickness seems relatively stable. But again, this patient needs close follow-up. So what's the conclusion of our post-cross-linking study? Well, post-cross-linking measurement, noise or variance can be used to determine progressive change. The noise measurements, at least on our testing, were consistent across different centers, and we only looked at 2. They were consistent after 12 months post-operative period. And again, the new post-cross-linking confidence intervals says will be, but have been added to the 3rd iteration, and that Belin ABCD Progression Display III was just released. I'd like to again acknowledge this is my statistician at the University of Arizona, residents who have worked with me, and then again the people from both Elser Institute and Hamburg who obviously provided critical information for this display. I want to thank you for your attention. I think we're pretty much on time, and
Thank you.
Appreciate your attention.
Thank you very much, Professor Belin. As always, a pleasure listening to you, and this was a very informative session. Before, I would like to ask the audience, if you have questions, please write it in the Q&A. And before we look at a question or two, for the Professor Belin mentioned, it's just been released. So please contact your local OCULUS distributor if you do not yet have the latest edition. It's version 1.25 of the software. And if you update your device, you will have the post-cross-linking data included as well. So Professor, one of the questions that has come in is regarding the setting of the baseline. The user can manually set the baseline. There's options, but should it usually be the first examination when a patient come in, or is there a reason why someone can set to another examination to?
Yeah, good question. 99.9% of the time, you're going to leave it at what the machine does, which is the first exam. So is there a time when you want to manually change it? I'll give you an example. Let's say you had a patient, again, keratoconus. You've done a procedure. Let's say you put rings in. You want to follow the patient. And you have pre-ring and post-ring. So you may then decide that your new baseline is when you put rings in or some other modification. But in general, you want to follow, it'll be the first exam. So again, sometimes you'll do some changes or minor procedures that may alter the normal tomography, and then you may want to define what your new baseline is.
Okay, thank you. And then another question for you is how often do you follow up your patients to monitor if there's progression occurring?
Okay. So one thing you'll notice, whether it's the bad display, whether it's the ABCD classification, or whether it's the progression display, the one thing when I say we, myself and OCULUS, do as opposed to some other machines, we never say, well, this is 22.3% keratoconic chance. This is information, but you as a surgeon have to make clinical decisions. So the follow-up is going to vary on a number of things. Obviously, young patients will be followed much more closely. If I see a new young keratoconic patient, I may see them in 6 weeks, and then if they're stable, spread it out. But my older patients, 50-year-old, I may see on a yearly basis. A lot of it is what we normally, on normal practice patterns. The advantage of this is that it allows us to see very early change, and clearly, if you're seeing very early change, you'll see the patients more frequently. But this is, again, something that really is the surgeon's decision.
Thank you. That looks like all the questions that has come in. Allow me to thank Professor Belin once again, and to all of you who attended this session, thank you for taking time out of your day, and we wish you a happy day, morning, evening, wherever you are. Till next time. Goodbye.
A very early morning for me.
Yes. Stay safe.
Thank you. Take care, everybody.